Hi, I'm Donna Gairns. I'm the Lymphoma Nurse Manager with Lymphoma Australia, and we're here today at ASH 2019 in Florida, Orlando, day 3 of the conference. And I'm joined today by Dr. Brian Koffman from the CLL Society here in the US. Hello, Brian.
Hi, thank you for having me here.
Thank you for coming to speak with us today. Now, you're quite very big patient advocate especially in the States and globally, about CLL. And you're actually a patient yourself, and I know it's a bit of a family effort working together with the CLL Society. I just wanted to get some of your thoughts about what abstracts and what presentations have really taken your notice.
There's treatments for chronic lymphocytic leukemia have been changing at a breakneck pace, and there's all kinds of new options that are being offered, and ASH is where all these new things are presented for the first time. So there's a lot of things to talk about. Let me start by talking about one of the most exotic, which is CAR T therapy, and Tanya Siddiqui presented an abstract on that, where it was showing very strong results with well-controlled adverse events with people that were really at their end of the rope. The average patient had had 5 different treatments before they'd gone in. They'd really run out of options. And for the patients who'd failed drugs like ibrutinib and venetoclax, all of them were responding to CAR T therapy with deep responses. So this is very encouraging, exciting data. But this wasn't all. We found that combinations of drugs, combinations of novel therapies put together, like venetoclax and obinutuzumab, or ibrutinib and venetoclax, were getting a majority of patients in some cases to where their cancer was no longer detectable in their peripheral blood. This is really deep, deep remissions, often with a fixed duration therapy where patients could stop taking the drug and then glide for a long time. We started to look at the sequencing, what makes the most sense, which drug should we be giving first, which drug should we be giving later. So these are some of the highlights. Also, there was a whole bunch of new drugs. So people who develop resistance to the present generation of BTK inhibitors like ibrutinib, acalabrutinib, have drugs that are coming online that bind differently, and they presented very encouraging, very promising, but very early data on options for patients that might be helpful if they become resistant to drugs like ibrutinib. We talked about whole not new classes of drugs, but drugs that have been available but maybe underused, called PI3 kinase inhibitors like duvelisib and other drugs that are in development, with very encouraging results and how effective they are.
It's amazing. I mean, the landscape in the chronic lymphocytic leukemia area has changed dramatically since I've been involved in heme over the last 20 years. It must be incredible trying to keep up with these medications and knowing there's so many options for patients there, and people being able to live with CLL for many, many years.
So those are really excellent points, and we would push that in 2 directions. The first is that it's not only hard for patients to keep up, it's hard for hematologists to keep up. And that's why, unless somebody wakes up in the morning, thinks about CLL, and goes to sleep thinking about CLL, that they're a CLL specialist, that's what they do, sometimes they're not on top of the latest changes. And that's why we're very pushy at the CLL Society to make sure patients have access to the top experts, because we believe that there's a survival advantage, and there's actually studies that have shown that. We're presenting a paper tonight at ASH that based on that research, that expert access in our model, we're using a telemedicine type platform, improves patients' outcomes. So we're really excited about that part of the piece. The other thing that's happening is the issues in CLL are shifting. So we're having to look more at survivorship now, because we're living longer. We're having to look more at the important role of caregivers in CLL, which, my wife is my caregiver. She often feels invisible. Everybody wants to, the patient, and caregivers feel guilty if they try to get any attention. and they play such a vital role. You can't do this. Cancer is a team sport. You can't do this on your own. You need a team behind you.
Totally. And it's probably, correct me if I'm wrong, but probably a lot of your friends and family externally as well probably don't understand what you're going through, because generally looking at a patient, sometimes they look well, but not understanding that there is a disease and living with that disease for a long time.
Yeah, I think this is one of the more difficult things is for patients to be told how well they look when often they feel miserable. And we understand our friends are well meaning and they're trying to make you feel good. One of the things I always get a humor out of it, people tell me, well, you look so good now. Last time I saw you didn't look that great. But I remember that last time I saw them, they told me how good I looked, right? So it's like,
Thank you.
I'm trying to think, well, which time should I believe them, so, right.
So
Yeah.
it'd be really quite difficult
Yeah.
to live with, but it's really good that you mentioned the carers, and we all need a support network
Right.
around us. So in your own journey, I don't really like that word, but in your own experience with CLL, how long have you been living with the illness, and what is your sort of your history coming to today?
So I was
Medically.
diagnosed in 2005, so it's over 14 years now since I've had CLL, and I've had a rather aggressive form. So CLL is very heterogeneous. That means it's very variable. So some people live a normal life, don't need ever treatment. I wasn't like that. I needed treatment relatively quickly. I had a lot of complications, multiple hospitalizations. And when I was diagnosed, none of these treatments that are available and that are saving lives were available at that time. So I went to a bone marrow transplant from an unrelated donor, what's called an allogeneic hematopoietic stem cell transplant, but that didn't work for me. And then I did a couple things here and there and managed to get into a phase 1 trial. So phase 1s are the first trials, and I started a new targeted therapy that didn't have a name; it just had a number. But later it became ibrutinib, which revolutionized the care. That stopped working for me after about 6, 7 years. And then I switched and got CAR T therapy, and I did that about 20 months ago. And I'm happy to say my CLL is knocked down to such a low level that it's no longer detectable. I'm thrilled.
I imagine that would have been such a relief for yourself and your family as well, to be able to be said that there's no detectable disease. What sort of advice would you give patients who are diagnosed with this illness, and how to cope with waiting for that disease to progress or not progress?
Well, our motto at the CLL Society is smart patients get smart care. So I suggest that in CLL, besides all the anxiety you get with the diagnosis, you get time. And so front load your knowledge, become experts, visit our website, cllsociety.org, and learn about your disease. Talk to other patients. We have support groups in the US, lots of organizations can put you in touch with other patients and stuff, because there's things if you talk to another patient who's had the disease for 20 years, they can tell you things that a doctor could never tell you. So become aware, build a team of people, make sure you're comfortable with your physicians, make sure you have a support network of family and friends to help you, because you have time to put all this together. It's very rare that you have to make an immediate decision. But I do tell people to kind of expect the unexpected. Things do take twists and turns, and that ultimately you're going to have to make life-changing decisions with incomplete knowledge and conflicting advice, because there is not one way to treat CLL. There are multiple ways, and different doctors will give you different advice, and different friends, well-meaning, will give you different advice. So ultimately you have to make these decisions with conflicting advice. That's why I say front load yourself with knowledge, be aware, know what you want, know yourself in moving forward with this.
There has been a little bit of talk during the conference and over recent years as well about genetic testing prior to having treatment for CLL. What is the landscape in the US? Do most patients get this test, or only if they know about it? In Australia, it's a little bit hit and miss at times, and we're still trying to get it
So-
funded too.
Yeah, so we have a motto here called Test Before Treat, and I'll show you my bracelet here on the camera. So,
Awesome.
and on the inside of this, it says if you're unmutated IgVH, or if you have 17p deletion, or if you're TP53 mutated, that equals no chemotherapy. So we keep it real simple. It fits on a bracelet. And why are we doing that? Because studies have told us that a significant majority of patients, especially when they're getting the second line therapy, are not getting their appropriate testing done. And without that testing, which is not only prognostic, but more importantly predictive of which treatments will work and which ones won't work, patients can often get the wrong therapy.
Yeah.
So we're very big on test before treat. We've developed a lot of stuff to help patients with that. We see that as one of the great unmet needs in CLL in the US and around the world.
Yeah. And it's definitely something in Australia we're working toward and advocating for a government to be able to make it a standard part of the treatment profile, and also be funded in Australia too. So it's in the process of getting that meetings going at the moment for those in Australia. And are there any other sort of update? Oh, I was just going to ask you as well is about your CAR T cell therapy. I know there's been a lot of talk about it, and I know I get asked a lot about it in Australia from patients. And I guess maybe just have briefly discuss how did you find the treatment and what some of the side effects that you received, and just so patients have a sort of a better idea of what is expected. It's not as easy as it sounds.
Right. So after failing ibrutinib, I'm very grateful because I got a real long run out of ibrutinib. I had to make a decision about what my next treatment option was. And because my CLL tended to be the kind that mutated and was quite aggressive, and I had some significant complications, it was very appealing to me to at least try a treatment that was potentially curative. Now, nobody can say CAR Ts are curative, but it can knock the disease down to such low levels that it's unmeasurable, and people who get unmeasurable disease from other kinds of CLL treatment often have extremely long periods without the disease coming back, like 15, 16 years, which starts to smell a lot like a cure if the disease hasn't come back after 15, 16 years. So it seemed to me I wanted to give up, a month of my life for a potentially toxic therapy, and I did have a pretty rough time through a lot of it. But most people who go through CAR T do not have any prolonged adverse events. They can get very sick, but almost always there is no residual problems. So you might have terrible fever, shakes, aches, you might get a little confused, you might have horrible headaches. And some people it's much worse. They're in the ICU, they're on oxygen, they're on medicines to raise their blood pressure, they can have neurological events, even seizures and stuff. But almost everybody completely recovers, and then it's done. It's like, it's over, and when I was restaged a month later, there was no detectable CLL in my bone marrow, my blood. My lymph nodes has essentially shrunk back to normal. And 18 months after, when I again was restaged, there was no CLL to be found in my body.
That's really wonderful news, and you're still feeling pretty well.
Well, I'm on the fourth day of ASH.
I
walking.
think we're all feeling about that way.
Yeah, right. So a little tired, but the fact is that I'm here, and the fact is that this year I'll have traveled almost 200,000 miles. So that's the year after getting CAR T therapy. I think that says something. Yeah.
Yeah, no, that's fantastic. No, it's fantastic to hear from your experience and some of your insights from the conference. And I'll be sure to put the CLL Society address and website and details on there, so everyone can join, have a look at the site. And I've had a look before, and it's plenty of fantastic resources. A lot of great support for CLL patients, and we really thank you for taking the time to speak with us, and also supporting a lot of the Australian patients. I do know that you do a lot of work there, so thank you.